pediatrics TB is only 10 to 15%. So the number says that it is quite common in children, and infants and young children have the highest progression risk, because infants and young children, they are not so much immunocompetent. That's why tuberculosis is common in young children, okay, particularly in children less than 5 years of age. So India contributes a significant global burden. There are so many causes due to poverty, due to undernutrition, due to overcrowding, lower socioeconomic conditions. So India accounting for a large number of cases of tuberculosis. And that diagnosis are common due to paucibacillary disease in children. Okay, paucibacillary means the disease is less severe. So diagnosis often remains undiagnosed. The child is suffering from tuberculosis, but the diagnosis is often missed. Okay. So the agent you are already told, Mycobacterium. There are few strains of Mycobacterium. I think you know all these: Mycobacterium tuberculosis, Mycobacterium bovis, Mycobacterium africum, Mycobacterium boniti. Have you heard the names? Okay, but most common is Mycobacterium tuberculosis and Mycobacterium bovis. Tuberculosis is the positive organism for humans, and less common is Mycobacterium bovis, which causes the tuberculosis in particular lymph nodes. Okay, so pulmonary tuberculosis is mainly caused by the tuberculosis, Mycobacterium tuberculosis, and extrapulmonary tuberculosis, that is tuberculosis from the some other sites other than the lungs. This is caused mainly by the Mycobacterium bovis, particularly lymph node TB. So tuberculosis usually spreads by which methods? Air droplets. Okay. So it is contagious disease, spreads by droplet infection, and congenital infection is also possible, but the possibility is very much rare. Okay, from vertical transmission from mother to child, it may also occur, but the possibility is very low. So what are the risk factors in children? Infants, I have already told you, they are immunosuppressed, and immunodeficient children, if the child is suffering from HIV infection, severely malnourished, or measles, etc. These cases are more prone to develop tuberculosis disease because they are immunosuppressed. One thing I must tell you, that tuberculosis, the agent, causative agent, Mycobacterium tuberculosis is present in almost every individual. Okay, you may get tuberculosis, Mycobacterium tuberculosis, the causative agent in yourself also, but you will not be infected. You will be infected, but you will not develop the disease. The agent, causative agent, may remain latent in your lungs. When there is immunosuppression, the disease will flare up. Okay. So let's discuss the pathogenesis. I will show the picture first. When the disease or causative agent, when it enters into our lungs, it first go where? It first enters the alveolus. Okay, alveolus. Then the agent is engulfed by some alveolar macrophages. Okay. Then the macrophages releases some cytokines and chemokines like interferon gamma, IL-6, etc. Okay. These inflammatory markers, they causes some inflammation surrounding the alveolar tissue. Okay, and ultimately causing a caseation necrosis. Okay, and if untreated or undetected, that inflammation may lead to the surrounding lymph node. Okay, have you got it? And the primary infection that occurs within the alveoli is known as the Ghon's focus, Ghons, Ghon's focus. Okay, and the lymph node and the primary complex, both of them are called primary complex. Okay, the primary lung focus, where the disease mainly originates, the primary lung focus along with the regional lymph node, they are collectively called the primary focus. Okay. Here you can see there is inhalation of the organism through the trachea and bronchus, and the disease first starts here, okay, within this segment of the lung, within this alveoli, followed by engulfment by the macrophages and release of some cytokines, followed by caseation, and this is the Ghon's focus or Ghon's focus, okay, area of the lung where the disease first starts. Then if untreated, this lesion will then involve the regional lymph node, that is the here the lymph node, okay. So that is enlargement of the lymph node. Now Ghon's focus along with the lymph node, they are collectively called the primary complex, okay. And what is progressive primary disease PPD? When primary complex enlarges, they causes some caseation, means more severe disease. Disease is progressing, causes consolidation, collapse, or even obstruction to the local bronchus, okay. So this is known as progressive primary disease. These are the grades or severity of the disease. Here you can see first there was some Ghon's complex, then lymph node involvement, then followed by what is this? This area, black area, this is cavitation, right. The child was untreated, the disease had progressed, now there is more involvement and cavity formation. So this is known as progressive primary disease, okay. না বুঝতে পারলে বলবে bronchial obstruction may resolve or regress or form bronchiectasis if untreated. Hematogenous spread, yes, hematogenous spread may occur. Remember, tuberculosis is such a disease that can affect any organ of our body except, একটা MCQ বলে দিই তাহলে, except tuberculosis can affect, it is such a disease that can affect any organ of it. Don't think that tuberculosis only affects our lungs. It may affect brain, it may affect heart, it may affect liver, kidney, joint, spine, etc. except hair and nails. Hair and nails, ঠিক আছে? Tuberculosis affect any organ of the body except hair and nails. It's MCQ. So hematogenous spread may occur and it may reach to our brain causing meningitis, tubercular meningitis. It may reach the bones causing osteoarticular tuberculosis. It may spread to the liver causing liver tuberculosis, spleen causing disseminated foci. Okay, so it can affect any organ of our body. Reactivation TB in adolescent. As I told that when a tuberculosis agent enters into our lungs, it may either be cleared by some innate immunity of the host, okay. It may develop as a disease if the individual is immunocompromised, or it may remain latent, okay. Nothing is happening right now. When the individual become immunocompetent, even after many years, the disease may flare up, okay. But in case of children, latent infection is not so common because they are already immunocompromised, particularly below 5 years of age, okay. So reactivation TB is usually seen in adolescent, either adolescent or adult, okay. And the cases are more common when the disease is particularly involves the apical segment of the lung, okay, particularly the right lobe. What are the general features of tuberculosis? You know all this, that is fever. Can anybody tell me when will you suspect that this child may have tuberculosis? For fever for how many days? 2 weeks. 2 weeks. Fever for more than equal to 2 weeks, okay, fever. And also cough, no fever but cough. The child is having cough for more than 2 weeks. You will have to suspect that the child may have tuberculosis. Weight loss, there is a criteria. Weight loss, all changed. These were previous criteria. 5%? 5% is correct. 3 months. 5% in last 3 months, okay. 5% of what? Previous maximum body weight in the last 3 months. Body weight is changing every day, na? Huh? So more than equal to 5% weight loss in last 3 months. Okay. So fever of more than equal to 2 weeks without any identified cause. Number 2, cough for more than 2 weeks and loss of weight more than 5% in the last 3 months. These are 3 main clinical suspicious criteria for tuberculosis. Okay. And another associated symptoms like weight loss, poor growth, fatigue, night sweats, etc. Primary pulmonary TB symptoms are mainly respiratory symptoms like cough, wheeze, airway compression. When the disease affects the bronchus or the bronchial tree, they may present with wheeze, and the child, you may think that it may be a case of asthma, but ultimately it may come out as a tuberculosis. Okay. And collapse or emphysema in later stages. Endobronchial TB, that is, I have told that if there is compression on the bronchus, the child may present with barking cough, persistent wheezing, segmental collapse that mimics asthma. Miliary tuberculosis. Have you seen any X-ray of miliary TB? Miliary TB, miliary mottling in both the lungs. This is the miliary tuberculosis, miliary mottling in both lungs. Okay. So miliary tuberculosis mainly present with high grade fever. Okay, sudden high grade fever, tachypnea, hepatosplenomegaly, irritability, and chest X-ray show miliary mottling. So pleural effusion. If there is involvement of the pleura, okay, there is accumulation of some fluid. Okay, so that is pleural effusion. Have you seen any X-ray of pleural effusion? Effusion একদম সাদা হয়ে যাবে, হোয়াইট লাং. ওকে, হোয়াইট লাং, রাইট, ম্যাসিভ প্লুরাল effusion. Okay. And tubercular lymphadenitis, the regional lymph node may also be affected by the tuberculous agent, and it causes drainage of pus. This is the axillary lymph node. Okay, large lymph node, and this is the pus point. Child presenting with lymph node is very much common in our OPD. Okay, often the mother will tell you that my child is having such swelling. They often think it as tumor. Okay, they may panic. Okay, that's tumor, that swelling. Okay, most of the cases these lymph nodes are asymptomatic, but if you get any significant lymphadenopathy that is more than 1.5 centimeter in diameter, okay, don't underestimate it. Okay, go for investigation. Okay, you do the routine blood count, you may get the FNAC, that is fine needle aspiration cytology, you may get some tubercular agent from the lymph nodes. Okay, so childhood, remember, in children extrapulmonary tuberculosis is more common than pulmonary tuberculosis. Okay, so in children you will not, in medicine you will get lots of patients with pulmonary TB. They may present you with fever, cough, etc., etc. But in children you will rarely get such pulmonary tuberculosis, fever, cough, etc. You will get these cases, lymph node. Okay, so extrapulmonary tuberculosis is more common than pulmonary in case of children. Remember it. Okay, so you should have a high index of suspicion that these cases may come out as tuberculosis. Okay, abdominal tuberculosis. I have told TB can affect any organ of our body. So abdominal tuberculosis is quite common. This is also extrapulmonary tuberculosis, lymph node TB, abdominal TB, tuberculoma. These are quite common in children rather than pulmonary TB. So abdominal TB present with chronic pain abdomen. A child is suffering from pain for last 3, 4, 5 months, and lots of antacids are taking, lots of PPI, গ্যাস থেকে হচ্ছে, পেটে ব্যথা হচ্ছে, হ্যাঁ, তো যেটা হয় গ্যাসের ওষুধপত্র খেয়ে এলো, তোমার কাছে এলো, তুমি দেখলে বাচ্চার ওয়েট কমে যাচ্ছে, বাচ্চা ক্যাকেকটিক লুক, পুয়ার অ্যাপিটাইট, হ্যাঁ, নাইট সোয়েটস, তো এনি লাম্প ইন দ্য right lower quadrant. Okay, so there is formation of a lump, that is most common site is terminal ileum and cecum. You will getting a lump Okay. So, and if in USG there is a very common findings is mesenteric lymphadenopathy. Remember it, a very common finding. Okay, if the childhood pain abdomen is so common, almost one every 1 to 2 patient in 10 will present with pain abdomen. Okay, 10টা বাচ্চা হলে 1 থেকে 2টো বাচ্চা তোমার কাছে পেন অ্যাবডোমেন নিয়ে আসবে, and these parents often they will irritate you to write USG একটা লিখে দিন পেটে কি হয়েছে, and you will get the finding in almost 99% cases mesenteric lymphadenopathy, and they thought that the guardians that the pain abdomen is due to that lymphadenopathy, but this is a insignificant finding. Okay, just one routine examination you will get lymphadenopathy. But what I am trying to tell you that when the child is suffering from a chronic pain abdomen, recurrent pain abdomen, say for example last 3 months, 4 months, 5 months, and you are getting some clue of tuberculosis, that is weight loss, anorexia, there is some history of tuberculosis in the family, and you are getting some lump. In that cases you must look for that size of the lymph node. If the size of the lymph node, that is mesenteric, they mentioned it, the radiologist mentioned it, there is mesenteric lymphadenopathy, the largest lymph nodes measuring millimeter or centimeter. If the size is mentioned in the report more than 1.5 centimeter, that is more than 15 millimeter, you should go for FNAC of the lymph node. Okay, USG guided FNAC, and it may come out as abdominal tuberculosis. This is common, abdominal tuberculosis in children. Spinal tuberculosis, when there is involvement of the spine, it forms gibbus. I will show you the picture, gibbus. And there is risk of paraplegia, both the lower limbs will be paralyzed, and joint swelling and restricted motion. This is gibbus. Okay, involvement of the spine. CNS tuberculosis, it is also so much common. Child who is present with fever, irritability, and in older children you will get all the signs of meningeal irritation. Can you know the signs of meningeal irritation? Anybody? Neck rigidity and Brudzinski sign. Very good. Kernig sign, neck rigidity, and Brudzinski sign. Okay. So in case of older children, okay, but if infant you will not get these meningeal signs. Okay, you will see only fever, vomiting, irritability, and in severe cases convulsion. Okay, so CNS TB is quite common in children. What is this? In respect of TB, in this foci. Can it be tuberculoma? Brain TB, tuberculoma. Okay, tuberculoma. Have you heard any or any seen any CT or MRI plate of NCC, neurocysticercosis? Can you tell me the difference between NCC and tuberculoma? Okay, and tuberculoma? Maybe single or multiple. NCC, both, maybe, usually multiple, but maybe single. Another point? Okay, it will be discussed later. Okay, this is important clinical aspect. Okay, screening. Now coming to the screening, how we will diagnose the case. Okay, so there must be a household contact. If there is history of contact with a TB patient within the last 2 years, remember the duration, last 2 years. Okay, the child is presenting in our OPD today with fever, cough, etc. for more than 2 weeks, but there is history of tuberculosis in his grandparents who has passed away 5 years ago. Can it be a case contact? Can it be defined as a contact history positive or not? No. The grandfather has already passed away 5 years ago. The criteria says there should be a contact within the last 2 years. If the grandfather is alive and he is taking medicine or diagnosed with TB within the last 2 years, then we will think that this child should be screened for tuberculosis because there is a family history of contact. Okay, and so as I told that latent tuberculosis, that is tubercular agent, that Mycobacterium tuberculosis is present anywhere in the body, but the child is not showing any symptoms or signs of tuberculosis. Clinically normal child. Okay, this is called latent tuberculosis infection. Okay, I may get infected with tuberculosis, but I am not diagnosed or suffering from tuberculosis. Okay, in cases I am getting immunocompromised, say for example, I have diagnosed with some carcinoma or HIV, then the tubercular germs may flare up. Then I will be diagnosed or suffering from tuberculosis. Okay, so latent TB is quite common. And what are the tests to diagnose latent tuberculosis? There is no symptoms or sign of tuberculosis in the child, but tubercular germs is present in his or her body. So what are the tests? Can you test me? Can you name one to test? And one to test is so called old test and newer test. Can you name? Huh? জানার কথা নয় তাও জানতে পারলে ভালো জানিস কেউ IGRA. Okay, IGRA, Interferon gamma release assay test. Okay, so there are two tests to detect latent tuberculosis. One is Tuberculin test or Mantoux test, and another is IGRA. Okay, Interferon gamma release assay test. Okay, so what does the two tests do? What are the role of these two tests? They actually detect, Tuberculin test particularly detects delayed type of hypersensitivity. Okay, if any child is infected with the Mycobacterium tuberculosis, he may show some reaction by releasing the cytokines and the chemokines from the macrophages, and they show some reaction with the injectable PPD, that is purified protein derivative. Okay, so how the test is performed? There is 2 tuberculin, yes, 26 gauge needle, 0.1 ml, that is 2 tuberculin injected, and the test is interpreted after 48 to 72 hours. Okay, and what does measurement actually? What do we measure actually? Is it induration or it is erythema? Induration. What is induration? What is erythema? জানো ভালোই বলছিস বল, হোয়াট ইজ এরিথিমা অ্যান্ড হোয়াট ইজ ইনডিউরেশন? আমরা তো ইনজেকশন করলাম বলার অ্যাসপেক্টে, 72 আওয়ার্স পরে আমরা মেজার করব, ঠিক আছে? কি দেখবো? এরিথিমা দেখবো না? এরিথিমা মিনস রেডনেস, ওকে, অ্যান্ড ইনডিউরেশন মিনস thick swelling. Okay, so actually we should measure the induration, not the erythema. Okay, if the induration, that is also measured horizontally. Okay, horizontally by a scale. Here is a picture like this. Okay, like this. Okay, we should measure with a scale, and if the size is more than 10 millimeter, that is positive. If the size is 5 to 10 millimeter, but if less than 5, negative means the child is not having tuberculosis. If negative, may be positive, may be negative, but you should actually do the culture test. Okay, culture test. The lekha ache 5 less than 5 millimeter does not exclude TB. Okay, if positive, you may stamp it tuberculosis. Okay, but if less than 5 millimeter negative, you may not stamp it as the child is not suffering from tuberculosis. Okay, you should ideally do some other test. Okay, so what are the factors causing false positive and false negative result? False negative results is due to, actually this is a hypersensitivity reaction, and the reaction actually, which child will show this reaction? Actually those child who was immunocompetent. Okay, if the child is suffering from some immunocompromisation, then his or her body may not show the reaction. Okay, so if the child is suffering from malnutrition, immunocompromised state like HIV, viral infection, etc., then the result will be false negative. actually suffering from tuberculosis, but you will get negative result. And what are the causes of false positive result? If the child is already given BCG vaccination or there is some non-tubercular mycobacteria, okay. So in these cases, you may get false positive result, okay. So chest X-ray should always do. If we are suspecting pulmonary TB, we should go for the chest X-ray. So Mantoux test, chest X-ray. CT and MRI in childhood tuberculosis. Particularly if you are suspecting some tuberculosis in the brain. In case of adult, we may easily get the sputum, but in children it is very challenging to get the sputum. So there are some alternative methods to collect the sample, and these are gastric aspirate or induced sputum. Okay, how to collect the gastric aspirate? Actually, these sample are sent for the. Have you heard the name of CBNAAT? Gastric based nucleic acid amplification test. This is actually a test for to detect the DNA of the mycobacterium, and along with if there is any resistance to the rifampicin, the mother drug of tuberculosis. Okay, so CBNAAT, to collect the sample, you will have to do the test in your hospital when you will be interned. Actually, the child should be overnight fasting, okay, and in the morning you should do a Ryle's tube and you should collect the gastric aspirate to keep it in a sample. There is a bottle for collection of the sample for CBNAAT, and ideally if you are suspecting pulmonary TB, you should send for 2 sample ideally, okay. And gastric aspirate is recommended in young children, and induced sputum is done in case of older children, okay. How induced sputum is done? Actually, before doing the test, the child should be given salbutamol nebulization. Then the child is given some nebulization with 3% saline, okay, hypertonic saline. That is induced sputum is collected. So I have told it through CBNAAT that detects the TB DNA along with whether there is rifampicin resistance is present or not. Is highly recommended in initial test, okay. Actually, nowadays tuberculin test, chest X-ray, all are gone older. This is the first line test, okay. CBNAAT, it can be performed from any sample, okay. It can be a test from the sputum, from CSA, from peritoneal fluid, from synovial fluid, okay. So the test doesn't depend which organ is involved. The test can be performed from any sample. Culture method. When I said when you are getting Mantoux test negative, you should ideally go for the culture test. When you are getting tuberculosis, when you are suspecting drug resistance, you should do the culture test. MGIT means Mycobacterium Growth Indicator Tube. This is a culture media, liquid culture media. Have you heard the name? Can you tell me the culture media for Mycobacterium tuberculosis? Which media in microbiology? ALJ media. Full form? Is it a solid media or liquid media? And this is the liquid media. Okay. LJ is solid, MGIT is liquid, tube. Okay. And the results is quick, 1 to 2 weeks compared to LJ media, that is 3 to 4 weeks. IGRA, what I was telling you, IGRA. Interferon release gamma as a test, that is a little bit costlier test, but results are obtained within 1 hour, okay. So actually these tests are done in high profile patient, so not WHO not recommending these tests in our country, okay. পরে নাও যারা জানতে চাও, interferon gamma release assay is a blood test used to detect tuberculosis infection by measuring the body's immune response to TB bacteria. It works but by identifying the release of interferon gamma, a protein produced by white blood cell when exposed to the TB antigen, okay. When infected, the macrophage will release the interferon gamma, that's chemokines, and this test assay the quantity of the interferon gamma or the number of cells released which releases interferon gamma, okay. Diagnosis of extrapulmonary tuberculosis. depends on the involvement of which organ is involvement, whether it is a lymph node, whether it is abdomen, CNS or spine. Now coming to the last point, that is treatment of tuberculosis. It is multi-drug therapy and adequate duration, weight-based dosing, adherence monitoring, all are under RNTCP guideline, but the name has already been changed. Have you heard the name RNTCP? National Tuberculosis Control Program, but from 2020 the name is changed National Tuberculosis Elimination Program, NTEP. Okay. The treatment regimen, you will have to remember this throughout your whole medical career: 2 HRJD plus 4 HRE. Okay. Newly diagnosed pulmonary TB, newly diagnosed extra-pulmonary TB. The regimen is same in case of all children. Okay, 2 HRJD plus 4 HR. H, what is H? Isonia Z. What is R? Z? E? S? Streptomycin. All are orally taken except streptomycin. Yes, it is injectable. What are the key toxicities? HRZ causes hepatotoxicity, and this is important MCQ question. Ethambutol causes retrobulbar optic neuritis. Retrobulbar optic neuritis. Okay. Hypersensitivity can occur due to any drug. Okay. Steroids. Steroid. Why are you giving steroids? Because I have already repeatedly tell in this class that tuberculosis actually happens when there is some immunosuppression. The child or the people individually suffering from immunocompromised state, and we are giving again steroids. So what is the basic, what is the logic behind giving steroids? কে বলতে পারবে স্টেরয়েড কেন দেওয়া হয়, কখন দেওয়া হয়? এটিরই তো দেওয়া হবে, অ্যান্টি টিউবারকুলার ড্রাগ টিবি ট্রিটমেন্টে দেওয়া হয়, বাট হোয়াই স্টেরয়েড ইজ গিভেন ইন টিউবারকুলোসিস? বলো। Very good, very good, very good. When there is interaction between the host and the agent, okay, there is release of some cytokines and chemokines like INF, gamma, IL-6, etc. And these cytokines causes some inflammation to the host also. Okay, to suppress this immune reaction, we have to give steroid, but not in all cases. These are the specific indication. There are some cases. These inflammatory reaction, what they causes, what they causes some raised ICT. If the child is suffering from meningitis, CNS meningitis, there will be TB meningitis, there will be raised ICP, hydrocephalus formation. So you have to, if there is involvement of the pericardium, there will be constrictive pericarditis. So there may be development of the complications, and you will have to stop that complication by suppressing the immunity, by suppressing the inflammation. Okay, and there are some indication of giving steroid, not in all cases. Child is suffering from pulmonary tuberculosis, you will not have to give steroids. Okay, there in that case only give ATD, anti-tubercular drug. But what are the indications of giving steroid? You have to remember this: TBM, pericardial tuberculosis, airway obstruction, that is endobronchial TB, when there is obstruction of the bronchus. Okay, severe miliary tuberculosis. So these are the few indications of giving steroids. Which steroid? Prednisolone. Dose is 1 to 2 milligram per kg per day for 4 weeks, then tapering the dose for the next 4 weeks. Or dexamethasone, 0.6 milligram per kg per day. TB newborn, is it possible? I have told you that tuberculosis mainly spreads by droplet infection, but vertical transmission is also possible. Though it is rare, but it is possible. Newborn baby, that is less than how many days? Newborn? Newborn? Newborn কাকে বলে? এতদিন পড়ানো হলো তো। Newborn কতদিন? হ্যাঁ, 28 days. সবাই বল, জোরে বল, 28 days. নিউবর্ন পিরিয়ডে যদি টিবি হয় তাহলে কি করবি? নিউবর্ন পিরিয়ডে স্ক্রিনিং করবো আমরা, প্রথমেই ডায়াগনোসিস করতে হবে, যেগুলো বলা হলো, তাই না? যে CBNAAT করবো, তারপর ইনডিউসড স্পুটাম করে দেখবো। যদি টিবি থাকে তাহলে তো ট্রিটমেন্ট দিতে হবে, আর যদি টিবি না থাকে তাহলে কি করবো? ইফ অ্যাসিমটোমেটিক গিভ INH প্রোফাইল্যাক্সিস। এই কথাটা জেনে রাখবো, INH প্রোফাইল, এটা একটা নতুন টার্ম, INH প্রোফাইল্যাক্সিস। দ্যাট ইজ any child, not newborn, not only newborn, any children who are there is history of contact but disease is excluded. Okay. Suppose a father is suffering from tuberculosis and his child is 3 years old. Okay, father is already diagnosed. So what should you do? You should ask the child also. You should exclude whether the child is active TB or not by doing the test, CBNAAT, chest X-ray, Mantoux test. If all tests are negative, what should you do? Child is below 5 years. What should you do? You should give him INH prophylaxis. Okay. 5 বছরের নিচে যে কোনো বাড়িতে যদি কারো টিবি হয়, 5 বছরের নিচে যদি কোনো বাচ্চা থাকে তাকে কিন্তু আমরা আনট্রিটেড রাখবো না, তাকে আমরা আইএনএইচ প্রোফাইল্যাক্সিস দেবো। ওকে, ফর হাউ মেনি ডেজ? 10 মিলিগ্রাম পার কেজি পার ডে ফর 6 মান্থস। ওকে, আইএনএইচ প্রোফাইল্যাক্সিসের সঙ্গে কোনো ড্রাগ দেওয়া হয় এটাও বলে রাখে। আইএনএইচ প্রোফাইল্যাক্সিস, দ্যার ইজ ওয়ান ড্রাগ দ্যাট ইজ অলসো গিভেন অ্যালং উইথ আইএনএইচ। কি কোন ড্রাগ? ফার্মাকোলজি যারা ভালো পড়েছে তারা বলতে পারবে। বল, আইএনএইচ প্রোফাইল্যাক্সিসের সঙ্গে কি ড্রাগ দেওয়া হয়? বল বলছিস, বল। পাইরিডক্সিন, রাইট। কেন দেওয়া হয়? হ্যাঁ, বিকজ আইএনএইচ কজেস আইএনএইচ হোয়াট, কেন পাইরিডক্সিন দেবো কেন, কি জন্য? It hampers the metabolism of the pyridoxine. Okay, it causes some problem in conversion of the active form of the pyridoxine. Okay, that's why pyridoxine is added. Okay, and due to deficiency of the pyridoxine, there is development of the peripheral neuropathy, and peripheral neuropathy is diagnosis in children is very tough. So that's why it is already recommended that when you are giving INH, you should give INH pyridoxine along with INH. Okay. So that is written in children less than 5 years contact screened. If disease is excluded, you should give INH prophylaxis for 6 months. Monitoring therapy, assess clinical, radiological and repeat chest X. Chest X কখন করব? We have started anti-tubercular drug, and when will you repeat the chest X every day or every month? Remember, only 2 times, after 2 months of starting IP, that is initiation phase, and at the end of the treatment. Okay, 2 times. Chest X-ray is done twice. But you should assess the weight gain, appetite, generalized sensorium, etc. every time the child is coming for follow-up. Drug resistant. This is the last of today's discussion. Drug resistant tuberculosis. Okay. When will you suspect drug resistant? When there is, I have told you, we will do chest X-ray after 2 months. Now the child is taking the drug for the last 6 months, well complied, is taking regularly, no drug missed, dose is accurate, but there is no improvement in the chest X-ray. Okay, so in that case you will have to suspect that this child may have drug resistant tuberculosis. Okay, if there is no improvement, that should be confirmed with the CBNAAT or culture or drug susceptibility testing, DST. Definition of drug resistant. Drug resistant TB refers to TB caused by strains resistant to the one or more first line drugs. So what are the first line drug? একজন বলো। হ্যাঁ, HRJD, আরেকটা বলবি না? Yes, তাই না, সেকেন্ড লাইন তোমার অ্যামাইনোগ্লাইকোসাইড অ্যান্ড ফ্লুরোকুইনোলন। So if the child is suffering from resistant to one or more drug of the first line generation, first line drug. Okay, and what is এই definition গুলো আমি পরে বলছি। If the child is resistant any one or more of first line drug, that child is should be defined as MDR-TB, drug resistant TB. Okay, drug resistant TB, not MDR. Epidemiology, it is also quite common. 3 to 7% of all TB cases, childhood TB cases are due to drug resistant. It's very difficult to manage drug resistant TB. Okay, injectable or injections. Okay, that should be also for 2 years. That MDR-TB, এমনি বাচ্চারা ওষুধ খেতে চায় না, তার মধ্যে আবার 2 বছর যদি একটা বাচ্চাকে দিয়ে ইনজেকশন দিতে হয়, so but the prevalence is not uncommon. 3 to 7% cases are drug resistant TB. Types of drug resistance. Monoresistance means the child is resistant to any one of the first line drug. Any one. Actor drug resistant. Mono means one. Poly means more than one. Maybe isoniazid, rifampicin, ethambutol, pyrazinamide, anyone. more than one. And what is multi-drug resistant TB? If the resistance is due to H and R, rifampicin and isoniazid. Okay, so what is difference between polyresistance and multi-drug resistance? Poly means resistance to more than one. Okay, not necessarily isoniazid and rifampicin, but multi-drug resistance means resistance to isoniazid and rifampicin. Okay, and what is XDR-TB? HRJDS plus fluoroquinolone or aminoglycans, all second line, first line plus second line. XDR, extensive drug resistance. Okay, কারা রিস্ক ফ্যাক্টর কাদের, কোন কোন বাচ্চাদের এরকম ড্রাগ রেজিস্ট্যান্ট টিবি হতে পারে? বা ওষুধ খেতে খেতে বন্ধ করে দিয়েছে, ওষুধ ঠিক মতো ডোজে খায়নি, যাদের HIV আছে, তাই না? তো তারা হচ্ছে ড্রাগ রেজিস্ট্যান্ট টিবি। কন্ট্যাক্ট উইথ এনি ড্রাগ রেজিস্ট্যান্ট অ্যাডাল্ট, বাবার হয়তো ডায়াগনোসিস হয়েছে ড্রাগ রেজিস্ট্যান্ট টিবি, সেই বাচ্চার হতে পারে ড্রাগ রেজিস্ট্যান্ট টিবি। হ্যাঁ, প্রিভিয়াস টিবি ট্রিটমেন্ট, পুয়ার অ্যাডহারেন্স, ওষুধ দেওয়া হয়েছে খায়নি, ম্যালনিউট্রিশন, HIV, প্রোগ্রেসিভ প্রাইমারি ডিজিজ, এইগুলো থাকলে ড্রাগ রেজিস্ট্যান্ট টিবি থাকতে পারবে। হ্যাঁ, কখন সাসপেক্ট করবো? ক্রনিক সিমটম ডেসপাইট অ্যাডিকুয়েট থেরাপি, তুই ট্রিটমেন্ট দিয়ে যাচ্ছিস কিন্তু ইমপ্রুভ করছে না, প্রোগ্রেসিভ লাং ডিজিজ, পারসিস্টেন্ট ফিভার, নাইট সোয়েটস, ওয়েট লস, নিউ লিম্ফ্যাডিনোপ্যাথি, ওয়ার্সেনিং চেস্ট এক্সরে হলে আমরা ডায়াগনস্টিক অ্যাপ্রোচ কী করবো? আমরা আমরা ওই যে যেমন বললাম ওই যে নতুন টেস্টগুলো করবো, কী করবো? গ্যাস্ট্রিক অ্যাসপিরেট করবো, ইনডিউসড পুটাম, ব্রঙ্কো অ্যালভিওলার লাভাজ অর লিম্ফ নোড অ্যাসপিরেট, কালচার, এগুলো করে দেখতে হবে আমাদের। চলো ট্রিটমেন্ট কী করবো? ট্রিটমেন্টে যে দেখে নাও, দুরকম রেজিমেন্ট আছে, একটা 9 থেকে 11 মাসের, আর একটা হচ্ছে 24 মান্থস। কী কী ড্রাগ দেওয়া হয়? এখানে সব সেকেন্ড লাইন ড্রাগগুলো দেওয়া হয়। BDQ মানে বেডাকুইনন, ঠিক আছে, লিভোফ্লক্সাসিন অর মক্সিফ্লক্সাসিন, ক্লোফাজামিন, পাইরাজানামিড। হ্যাঁ, লঙ্গার ডিউরেশন মানে 24 মান্থস, এই ড্রাগগুলো দেওয়া হয়, ঠিক আছে। সো ড্রাগ রেজিস্ট্যান্ট টিবি একটু জেনে রাখা ভালো, ডিটেলসে তোমাদের আছে। ড্রাগ রেজিস্ট্যান্স কাকে বলে, কী ড্রাগ রেজিস্ট্যান্ট হতে পারে, শর্ট নোট আসতে পারে ড্রাগ রেজিস্ট্যান্ট টিবি। ওকে, কাদের কোন হু আর দ্য রিস্ক ফ্যাক্টর, হোয়াট আর দ্য রিস্ক ফ্যাক্টর ফর ডেভেলপিং ড্রাগ রেজিস্ট্যান্ট টিবি, and how will you treat drug resistant TB? So what are the prevention of tuberculosis? Prevent কিভাবে করব TB? By giving BCG vaccination. Okay.